Okay, welcome everyone to our 33rd seminar of the Centre of Aphasia Research Excellence in Aphasia Recovery and Rehabilitation Seminar Series. I'm John Pearce, postdoctoral researcher here at the Aphasia CRE. And first of all, we'd like to acknowledge that this event and many of our attendees are located on the lands of traditional custodians in Australia, and I'm joining you today from Wurundjeri land. We pay our respects to elders past, present and emerging, and extend this respect to any First Nations people joining us online today. It's wonderful today to be hearing from Dr Sarah J Wallace, who is presenting on driving quality improvement through meaningful evaluation of aphasia services. And before I introduce Sarah formally, I'll briefly cover some housekeeping. Firstly, if you haven't already done so, it's a really great idea to join us as a member of the Aphasia CRE community of practice. Our community of practice includes over 1,200 members now, including people with aphasia, their family, friends, health professionals, researchers, and organisations. And members receive a regular newsletter, updates about events and activities, contributions to research, networking opportunities, and more. And the CRE is always looking for financial support, so if you wish to donate, please see our website for details. In November this year, the Aphasia CRE is really pleased to be hosting the Aphasiology Symposium of Australia at La Trobe University's Bundoora campus in Melbourne. The symposium will provide high quality research and clinical innovation presentations through oral and poster presentations and lightning talks. And the symposium will be a really great networking opportunity to discuss and exchange ideas. This is an in-person event, not available as video conference, but we aim to video record most sessions, which might be viewed at a later date. Now, there is a small fee of less than $40 just for catering purposes, but no other registration fees. So if you're interested, please register online at aphasiasymposium.com. Please note that this seminar today is being video recorded. Past webinar videos are available via the Aphasia CRE website. Just click on the resources tab, and while you're there, have a look at our many other resources on that page. And please follow us on social media via Twitter and Facebook, and you're welcome to tweet along today and use the hashtag AphasiaCRE. If you have any questions throughout the seminar, please use the question and answer function on the Zoom toolbar at the bottom of your screen rather than the chat box. Enter your question for Dr. Wallace at any time throughout the presentation, and you'll be able to see questions asked by other audience members. You can like or upvote a question to show those of interest to the group, and Dr. Wallace will answer as many questions as time allows at the end of the presentation, but please reserve the Q&A space for questions only rather than comments, and please keep them brief. It's now my privilege to formally introduce Dr. Sarah J Wallace. Sarah is a speech pathologist and NHMRC Emerging Leadership Fellow at the University of Queensland. She conducts research in post-stroke aphasia and communication disability in ageing. Sarah uses qualitative and mixed methods to explore the lived experience of communication disability. Using co-design and consensus methods, she works in partnerships with consumers, clinicians, and researchers to co-produce interventions and standards that support the production of meaningful outcomes. Within the Queensland Aphasia Research Centre, Sarah leads flagship projects in co-design of aphasia services and development and implementation of a minimum data set for clinical aphasia services. Sarah is the research officer for the collaboration of aphasia trialists and has an interest in reducing research wastage and improving the quality, efficiency, and accessibility of aphasia research. Now, my pleasure to hand over to Sarah. Thanks, Sarah.
Thanks, John. Can you see that now? Okay. Yep. Excellent. I'll just, there we go. Thank you, John, and thank you to the CRE for the invitation to speak today. So I'm talking about MEASuRES, which is a program of research that falls within the CRE Predictors program. And I'd just like to start by acknowledging the CRE as well as the NHMRC, the Queensland Aphasia Research Centre, and the collaboration of aphasia trialists, all of whom support this work. I would also like to acknowledge the traditional owners of the lands from which I am speaking today, the Jagera and the Turrbal people. I pay my respects to their ancestors and their descendants who continue cultural and spiritual connections to country, and recognise their valuable contributions to Australian and global society. So, as mentioned, I'm talking about measures today, driving quality improvement through meaningful evaluation of aphasia services. MEASuRES is a program of research, and as such, there are a lot of incredible researchers who have been, are, or soon will be involved in this work. And I'm very grateful for the experience, expertise, and creativity that they all bring to this work. So what is MEASuRES all about? It's about the fact that currently there's no systematic way of determining if Australian aphasia services reflect evidence-based standards or produce outcomes that are meaningful to people with aphasia. So individual clinicians measure outcomes and collect data within services, but this varies from clinician to clinician. And across these services, we have no real way of understanding how our services on a whole measure up. So why does this matter? It matters because data drives quality improvement. So we use data to evaluate our current practice and to identify areas that need improvement. In Australia, we have systems for collecting stroke and rehabilitation data. So we have the Australian Stroke Clinical Registry, AUSCA. We have the Australasian Rehabilitation Outcome Centre, AROC. And we also have the acute and rehabilitation audits that are conducted by the Stroke Foundation. But we don't collect much data specifically about aphasia care or outcomes. In terms of quality of care, the Stroke Foundation National Stroke Audit collects only 3 relevant process of care indicators. So these are indicators of the quality of care provided to patients. And they are the identification of speech communication deficits, assessment by a speech pathologist within 48 hours, and identification of management strategies for those found to have aphasia. And whilst these are a really good start, these 3 indicators alone can't tell us a lot about the quality of aphasia care. In terms of outcomes, our research has shown that there isn't a consistent or routine approach to aphasia outcome measurement in clinical practice. And routinely collected stroke global outcome measures often don't include items that are relevant to communication, or they're not presented in a format that allows people with communication disability to complete them. Plus, what does it even mean? So we have a client who has a stroke, they have aphasia, we assess their language on the WAB or the CAT before treatment, and then, after 6 or 8 weeks of treatment, and their scores improve by 7 points. Is that a successful outcome? How much improvement should we expect? And what does this score tell us about whether treatment should keep going, stop, change? How much change is enough? How do we interpret this? What does this number really tell us? So we also need a better way of interpreting our outcome data. So MEASuRES aims to use real-world data to understand and improve aphasia care and outcomes. It aims to support meaningful outcome measurement practices in clinical settings so that clinicians have the information they need to inform their clinical decision-making. And this is all with the aim of driving quality improvement in aphasia services. So, as mentioned, MEASuRES is a program of research. It includes 2 PhD projects, 2 externally funded projects. It's part of the CRE Predictors stream led by Professor David Copland, and it involves collaborations with the Collaboration of Aphasia Trialists. And there are 5 main aspects to this work. The first is the development and implementation of a minimum data set for aphasia services. And this is what I'm going to talk about today. Through our fantastic collaborations within the CRE, our PhD students Marissa Stone and Sally Zingelman are working to understand what is currently known about the outcomes of people with aphasia and communication disability through existing stroke and rehabilitation registry data. And this includes OSCAR, AROC, and the Stroke Foundation audits. We're looking at the measures used in stroke economic evaluations and undertaking mapping work so that we can better demonstrate the value of aphasia treatments. We're establishing benchmarks of meaningful change on core outcome measures so that we know when treatments are making an important difference. And we're working towards using this data to identify evidence practice gaps and then to develop interventions to close those gaps. But today I'm going to focus on that first aspect of this program of research, the development of a minimum data set in collaboration with people with aphasia, their families, researchers, and clinicians. So for anyone who's not familiar with the term, a minimum data set is basically a consistent set of data items that should be routinely collected within an area of healthcare. The idea being that if we collect this information routinely and consistently, that we can use it to monitor the effectiveness and quality of care in a particular area. So our minimum data set is focusing on 3 main areas: the person, their care, and their outcomes. So first, the person. What socio-demographic, stroke, and aphasia characteristics, so things like someone's age, the hemisphere of their stroke lesion, do we need to know to understand and really make sense of someone's care and outcomes? Second, their care. What processes of care should people with aphasia be receiving? So what are the indicators of high quality aphasia care? And finally, when we measure outcomes, how can we make sure that the numbers on a test booklet actually mean something? How can we interpret that data so that it can meaningfully guide our clinical practice? So first I'm going to talk about the work that we've done looking at the person, so patient or participant characteristics. And this project was a collaboration with Megan Isaacs at Quark and Maizun Ali and Marion Brady at Glasgow Caledonian University in Scotland. So socio-demographic characteristics like someone's age or sex, their stroke and aphasia characteristics like the severity of their stroke and the time since the onset of their aphasia can help us understand someone's care and outcomes. So for example, It can help us understand whether people with aphasia receive different care because of their geographic location or socioeconomic status, or how stroke characteristics, such as initial severity of a stroke, might influence someone's recovery and outcomes. These characteristics can also help us interpret and apply research findings to clinical practice. So when we're reviewing research evidence to choose a treatment, we want to know, are the participants in that study similar to my client on the ward? Is this treatment likely to have the same benefits for them? And if we all collect the same characteristics, it makes it easier to compare and combine data. So when we're pulling together lots of different data sets, for example, in an individual participant database, or conducting, my light's gone off, it's automatic. I'll just have to do a bit of mid-presentation cardio here with my arm. There we go. Or conducting a systematic review or meta-analysis. So currently, we talked about this before, we don't collect much aphasia-specific information in clinical practice. In research, we collect a lot of information about participants, but it's inconsistent. It's inconsistently collected and it's inconsistently reported. And Brookshire was talking about this as far back as 1983. And then the Release collaboration, we're talking about this still in 2020, and the limitations that this was presenting to their work to conduct meta-analysis of individual patient data. So it's problematic because it makes it harder for us to make the best use of our data, and it's a barrier to gaining greater understanding of the factors that are resulting in better outcomes for people with aphasia. So our study, which we call Describe, sought to gain international and multidisciplinary consensus on reporting standards for participant characteristics in aphasia research. We conducted a 3-round eDelphi exercise, so an online consensus process, and held an international consensus meeting. So we started off in the first round by asking our stakeholders an open-ended question and getting them to generate the participant characteristics that they felt should always be reported in all aphasia treatment research. We analysed that data using qualitative content analysis and then combined it with items that we had identified from individual participant databases like Release and published audits. In the subsequent rounds, participants then rated the importance of each characteristic on a 9-point scale. And then those items that reached consensus, we interrogated further in an international consensus meeting that was hosted by the collaboration of aphasia trialists. And in this meeting, we considered those Delphi results and we thought about a couple of different things. So what is currently collected in research, what is important to collect, the characteristics that are known to influence someone's recovery, and how easy or difficult it would be to always collect and report these items. At the end of our process, we agreed on 11 characteristics for people with aphasia and 3 for communication partners. And we've developed a checklist that can be used not just when you're reporting participant characteristics, but at the design stage, so that you can be thinking about in research the characteristics which you should be actually building into your design and collecting. And this is available on the CATS website via the link on the screen there. And our plan in the context of our minimum data set is to collect these same characteristics so that we have data that's comparable to research and other data sets internationally. So that gave us our data items about the person. Next, we focused on care. What processes of care do we want to see happening consistently in clinical practice? So quality of care can be measured against performance indicators. And performance indicators that reflect decision-making, policies, or clinical practices are known as process indicators. So this could be something like all people who have a stroke being assessed by a speech pathologist within 24 hours. And we know that adherence to these process indicators are associated with improved patient outcomes. So they're really important. So we wanted to establish a set of process of care indicators that were backed by research evidence, that were important to stakeholders, that were measurable, and that were feasible to collect. So this is how we did it. So in 3 stages. Firstly, we reviewed clinical practice guidelines for recommendations with strong evidence. Then we asked people with aphasia and their families what is important to them. Then we held a 2-round eDelphi exercise with all of our stakeholders to get a top 10. And then we had a series of consensus meetings to try and operationalise these recommendations into something that is measurable. So first up was our updated systematic review of clinical practice guidelines for aphasia management following stroke. And this was an update of the systematic review conducted by Shrubsole and Associates, which was published in 2017. And that is current, the data in it is current until 2015. So we wanted to identify all clinical practice guidelines relevant to aphasia management after stroke that had been published since that time. We wanted to examine their methodological quality using the AGREE2 instrument, and then to describe and synthesize recommendations for aphasia management from the guidelines that had the highest methodological rigour. We're just finishing up this review currently, but we have found 9 high-quality clinical practice guidelines and 82 recommendations. So of these, 65 are evidence-based, 17 are consensus-based, 54 we classed as being aphasia-related, and 28 were aphasia-specific. When we compare this to our previous review, we've got double the number of high-quality CPGs, and so that's a great thing. It's great to see so much high-quality guidance being developed, but we're still only seeing around the same number of recommendations. So there's still some gaps to fill in our evidence base. So we took those findings and considered them in reference to the Australian Aphasia Rehabilitation Pathway, the AARP, and the Stroke Foundation Living Guidelines. So from the AARP, we extracted recommendations that were relevant to speech pathology practice with level 1 or 2 evidence, and that's using the NHMRC classification system. From the Stroke Foundation guidelines, we extracted any further relevant recommendations with strong evidence. And all up, this gave us 23 recommendations. So we understood what the evidence said about best practice, but we also wanted to know what people with the lived experience of aphasia thought. So in this study, we looked at the Aphasia United best practice recommendations. Aphasia United is an international peak body that aims to drive change by bringing together the global aphasia community. So researchers, clinicians, people with aphasia and families. And one of the key projects that Aphasia United has undertaken has been the development of multinational best practice guidelines for post-stroke aphasia services. So these are based on research evidence and have been developed with the input of over 500 international clinicians and researchers. But today, well, up until the point of this research at least, they had not had input from people with aphasia or their families. So we wanted to know, do people with aphasia and their families agree with the existing recommendations? Are the recommendations easy to understand? And are there any other recommendations that are essential for best practice aphasia services? And just a side note, our best practice recommendations are currently in transit to a new home and will soon be available on the Collaboration of Aphasia Trialists website. So we held focus groups and used the nominal group technique, a structured process where participants take turns to generate ideas in response to a question, and then rank and vote on these ideas. This was all happening in the beginning of COVID, so we rapidly transitioned this research online, which actually turned out to be a really good thing. It was feasible and it was well received by our participants. We held 8 focus groups with a total of 23 participants, and our sampling took into account variables including age of participants, their sex, geographical remoteness, and the severity of their aphasia. So we had 100% agreement from both of our groups, our stakeholder groups, that all 10 recommendations were relevant. So that was good news. However, 9 out of 10 of the recommendations were identified as needing changes to the wording to actually be understandable to people with the lived experience of aphasia. Participants with aphasia prioritised 28 new ideas for recommendations, which we synthesised into 7 themes. Significant others prioritised 23 ideas for new recommendations, which were synthesised into 6 themes. So firstly, people with aphasia. The most highly rated new recommendation was about aphasia awareness. So participants reported that all people involved in aphasia services should work to raise awareness about aphasia. Second was that people with aphasia should receive training, support, and access to technology for communication. Equal second, that people with aphasia should receive coordinated, comprehensive, and consistent care. The third most important theme was that people with aphasia should receive social support. This includes support to maintain relationships and opportunities to socialise and make new friends. And fourth, people with aphasia and their families should be offered psychological support. Fifth, they should be supported to build the skills they need to self-manage their recovery. And sixth was that people with aphasia should receive information about prognosis and factors that influence recovery. So they wanted to know, what will my recovery look like? How much better will I get? From the perspective of family and friends, the most important recommendation was that aphasia services should be person and family centred. So families and people with aphasia should be involved throughout rehabilitation. Second was that people with aphasia, family and carers should be offered social support. And this included information about available services, including conversation and peer support groups. Equal second was that people with aphasia, their carers, family members should be offered psychological support. Third, again, we had coordinated, comprehensive, consistent care. Fourth, that they should receive information about prognosis and recovery. And finally, that awareness, again, of aphasia should be raised in the general public and amongst people living with aphasia. So now we had our recommendations from the clinical practice guidelines, our evidence-based recommendations. We also had the perspectives of people with the lived experience. So how did they compare? This is a little bit of an overview of that process. So from the evidence, we got our 22 recommendations. From the Stroke Foundation guidelines, a further recommendation, so 23 in total. From the Aphasia United Best Practice recommendations, we got 2 further recommendations and 5 recommendations from consumers that were new. Some of these overlapped a little, so we bundled them up. And when we did that, we ended up with 23 recommendations. So it looked a little something like this. So this is only half of them so far. But the red recommendations came from the Aphasia United Best Practice recommendations. So these ones here about screening for aphasia using a valid and reliable tool, and that the person with aphasia should be assessed to determine presence and severity of aphasia. The purple boxes came from our focus groups. So integration of information about recovery and prognosis, person and family-centred care, support and access to technology for communication, psychological support, and support with self-management. So with our list of 23 recommendations, we wanted to establish some agreement about what was most important to measure, keeping in mind that it needed to be something feasible. So our 23 recommendations were presented to people with aphasia, significant others, clinicians and researchers, across 2 rounds of an eDelphi exercise. So that gave us a top 10. And we then took that top 10 to an online consensus meeting. And at the end of that process, we had 10 indicators of high quality aphasia services. And here are our top 10. So there's a lot of information there, but featuring here is our indicators about assessment, information and education, communication partner training, collaborative goal setting, person and family-centred care, access to therapy, comprehensive and individualised therapy, and evidence-based therapy. So the next step was to take that top 10 to a series of meetings with participants from our eDelphi. So they were a subset of participants. We had separate meetings with people with aphasia and their families and clinicians and researchers. And this was purely for logistical reasons and to allow extra time for communication support. Before the groups, participants received the indicators and relevant information. So the recommendation that they came from, the supporting evidence, the indicator, the proposed indicator, the purpose of collecting it, the timing of collecting it, what the actual audit question would be, what the response options would be, the numerators and denominators. So how many people receive the quality measure versus how many people are eligible to receive it. The source of the information, so where are we going to find this information from, and the actor, so who would actually collect that information. And the really tricky part was converting each recommendation into a measurable indicator. So we needed to make it into something that could be feasibly measured, but that still retained the essence of the recommendation And this was really, really difficult. So during the meeting, we asked a bunch of questions based on the quality indicator critical appraisal tool. So things like, does the indicator measure the issue of interest? So is it reflecting the recommendation? Is there evidence for the use of this in clinical practice or audit already? What's the evidence that it actually is associated with an important health outcome? Is it acceptable? Is it feasible? And after each meeting, each group received a summary of the other group's discussion. So everyone was apprised of what the other group had spoken about. And we undertook a very iterative process of revising those indicators based on that discussion and feedback. We then asked participants to vote for whether the indicator should proceed to piloting, which is our next stage. So they had the option of voting for inclusion with amendments, or exclusion, and we needed 70% agreement to progress. And this is where we ended up. So we have our topic areas there on the left and our indicators on the right. Our bottom two didn't make the cut, and that was really a combination of not being able to find a measurable way to really operationalise the recommendation, and not being able to come up with a feasible way of being able to collect it. But we have our other 8 indicators, which will go through a little bit of further refinement and will then be piloted. So we've got our person, we've got our care. Our final step here was looking at meaningful interpretation of outcome data. And this draws on some of the work that came from my PhD, which was the development of a core outcome set for aphasia research. And this came from a very similar place, actually, to a lot of this research, the idea that the outcome measures used in treatment research were all different. We weren't sure whether we were actually measuring what matters, what's important. We weren't sure if we were really using the best tools to capture the effects of our interventions. And we wanted to think about, what is the best way of choosing an outcome measure. So we developed a core outcome set, an agreed standardised set of outcomes that should be measured and reported as a minimum in trials of a particular area. So when we thought about what should be measured, we came up with language, communication, patient-reported satisfaction with treatment and impact of treatment, emotional well-being, and quality of life. During our consensus meetings that we've held, we established consensus on measures to go with those construct areas: the WAB for language, the GHQ-12 for emotional well-being, the SARQUAL 39 for quality of life, and the scenario test for communication. And we're still yet to find or develop suitable measures for the other 2 constructs. In our assessment of the ROMA-COS measures in those consensus meetings, we thought about reliability and validity and responsiveness. So we considered a range of measurement properties, but we didn't consider interpretability. So interpretability is not a measurement property per se. It's more the degree to which someone can assign qualitative meaning, so clinical or commonly understood ideas, to quantitative scores, so assigning meaning to numbers. And one way of doing this is by establishing minimal important change values. So minimal important change reflects the smallest measured change in a score that's perceived as being relevant by a patient. So in addition to the pilot of our process of care indicators, establishing minimal important change values for our core outcome measures is a next big step in our program of research. So where to next? On the screen here, you'll see some of our terrific PhD students, Sally and Marissa. So next, as I mentioned, it's about interpreting change. So establishing those minimal important change values on core outcome measures, doing some mapping work so that we can undertake better economic evaluations of aphasia treatments. We're looking at what is there already, the data that's there already through existing registry and audit data and data linkage. We will be implementing our minimum data set in a pilot and assessing the completeness of the data that's collected, as well as the feasibility and acceptability of collecting that information. And also on the horizon is the development of some of those measures which we are yet to identify for the Roma core outcome set, so the patient-reported satisfaction and impact of treatment. So if anyone's looking for a PhD opportunity, please get in touch. So that is it from me today, and I hope that's given an overview of some of the work that we are doing. There's a lot more to come, but thank you for your time, and I'm happy to answer any questions.
Thank you so much, Sarah. That certainly is a program of research. It's kind of processes within projects within you know, the overall aim. So thank you for taking the time to present that to us today.
Pleasure.
Some questions coming in, but I'll start with one that's come through just internally here. They've said a huge amount of work has gone into making sure the best practice recommendations are relevant, meaningful, and accessible to people with aphasia and close others. How feasible is it for clinicians to implement these statements?
Yeah, it's a good question, and that's something that we are constantly thinking about. So every process that we've undertaken, we've balanced what is meaningful and what is important with what is feasible and what is acceptable. So we've taken an approach where we have really incorporated the perspectives of clinicians right throughout, hoping that by doing so, we will have an end product which is feasible and acceptable. But it's also why we have, you know, this next piloting stage built in, because we really want to test that. There's a lot of pressures in clinical practice and a lot of, you know, information, data collection burden already. So that's not something we're wanting to add to. It's more about making sure when we are collecting this data, are we collecting the best data that we can be, that's going to be most useful to guiding clinical practice.
And how, before I throw to the other questions, I've just got my own, which is, you know, there are so many aspects to consider when you're ranking all these different aspects. How did you kind of weight some of them, you know, so, you know, feasibility versus importance, or?
Yeah, it's a good question. So we've tried to, I guess, you know, bring all those elements in. So our short list ensured that what we were looking at was backed by research evidence. So, you know, we wanted to be recommending processes that we know research tells us are effective. And then we, you know, also built in the opinions and perspectives of people with lived experience to make sure that what we were looking at was important. And then that final stage, it really came down to feasibility. And it was really tricky because some of the recommendations, I think as the previous question alluded to, we just couldn't work out how we would measure them in practice or even how we would implement them in practice. And that's, you know, also part of a broader body of work that's happening. So I do a lot of work with Dr Kirstine Shrobsol, who is looking at implementation of best practice. and closing those evidence practice gaps. And so this work really goes hand in hand with that work, because measuring is one thing, but we also need to make sure that we're implementing the right best practice recommendations as well.
Yep. There's a lot of questions here that say Kelly Mescal, but they're actually people who've just used a link that makes it look like it's her asking these questions. So I'm not sure who asked this first one, but the top 10 best practice recommendations derived from the people with aphasia and significant others identified coordinated, comprehensive and consistent care. What did the contributors to these recommendations perceive to be comprehensive? Is this about care that targets all aspects of the ICF, for instance?
Yeah, exactly. So when we talk about comprehensive care, we're really talking about thinking about the whole person. So in addition to, the things that we know people want, improving their language, improving their communication, it's those other aspects of the ICF as well. So really strongly coming through a big focus on psychological well-being and care, not just for the person with aphasia, but for family members as well.
Yep.
Social support. A lot of talk about a desire for peer support as well coming through, but really, just that. The ICF.
Yep. Next question. Thanks for a very clear presentation about heaps of important work. What is your vision for the longer term future of clinical data collection in aphasia? Are we aiming for the core outcome set to be routinely collected? How might this look in different parts of the world?
Yeah, it's a tricky one, and I think the long term, yes. So my long-term vision is for, I think, consistent data collection, certainly across Australia would be the dream. And we're really fortunate within the CRE to be working with people like Dominique Cadillac and Monique Kilkenny, who have really pioneered this kind of data collection in stroke more broadly with, the OSCAR registry and their use of linked data. So really, it would be wonderful if through this work we were able to identify like a few little sort of things which could be considered within existing data collection systems. So, making a case for potentially incorporating some of these items within OSCAR, within AROC, within the Stroke Foundation audits. But also, registries they're an enormous thing to set up, but it would be great, pie in the sky sort of thing to be able to collect more information about aphasia services specifically that we could use to drive quality improvement. But I also think there's something really important in just the fact that even if individual clinicians are collecting some of this data themselves, it's going to mean that they can think about the data that they're collecting, hopefully in a clearer way against what's collected in and reported in research and what's collected and reported in other prospective data collection systems internationally. So it's early days, but I'm hoping that there will be impacts at multiple levels.
Do you see that as clinicians, entering that data just in their routine notes and then retrospectively pulling that out in audits, or do you think they're entering it into a database in the first instance, or is that further down the track?
Yeah, I think it's probably down the track, and it goes to feasibility. I mean, the last thing we want is people sort of having to take multiple extra steps to obtain and understand this kind of data. But having a registry where it's entered into, for example, requires a lot of infrastructure and governance and all sorts of things. So, I mean, I think within individual services, people can be collecting information and then auditing their own practice within their teams, so at a local level. But yeah, we will need better infrastructure if we are wanting to do that on a bigger scale.
Next question. I'm not sure if this is in your area or not, but thanks, Sarah. That was very helpful. I believe you mentioned that one of your recommendations for those with aphasia was mental health supports. I find barriers to clients accessing psychology support is their communication and psychologists' comfort levels with supporting this population. Has this been found to be the case in your research? Has a means of overcoming this barrier been identified?
So yeah, so this is not my particular area of expertise, but there's, you know, tons of fantastic work being done within the CRE by people like Brooke Ryan, Ian Kneebone, Caroline Baker, all of those people who are doing a lot of work looking at stepped care and the need for psychological support more broadly. So I probably can't answer that question specifically, but I would refer you to their work because they're doing some great stuff.
Yep. Questions are still rolling in. Kelly again. Thanks, Sarah. It's such an important comprehensive program of research. Do you imagine the process of care indicators will be applicable to all settings, or do you think some will be more relevant to some settings rather than others?
Yeah, so one of the things, and this was actually really interesting when we looked at the indicators amongst the clinicians and researchers, and then our second group was with our people with aphasia and family members. And for them, every single comment was about timing. And they were so vocal and strong on that point that there are certain processes of care that have to happen before certain, particularly transitions in care. And aside from answering your question, that for me was really exciting because it really, I think, emphasised how important including lived experience in these research processes is, because they just had a completely different focus to the clinicians and researchers. Having said all that, these indicators are mostly within the subacute period of rehab. So we're looking at when people are still in hospital. So I think the first indicator is about screening, which is probably our only acute indicator. The other indicators are, we're looking at inpatient rehabilitation. But you're quite right, you know, things don't end when you get discharged home. In fact, they often are just beginning at that point in a lot of ways. So I think data collection and looking at processes of care in community settings will be another whole step in this process.
It's interesting, that timing, because, you know, a service might tick off every single recommendation, but if they weren't done at the right time, that still might not be what people with aphasia were after.
Exactly. So yeah.
Another domain to capture.
Yeah.
In future. I'm not sure if this one's relevant or not. Catherine Rampant said, it's amazing research. I was just wondering what prediction about progress and recovery you make. Especially for me, I have mild aphasia, but when tired, stressed, my aphasia is much worse.
Yeah, thank you for that question. And I think that's something that we're all wanting to know the answers to. And that's actually how this research fits in to the CRE predictors stream, because a lot of the information that we're talking about collecting hopefully is going to shed some light on what factors actually do result in a better recovery, a better outcome for people with aphasia and their families. So there's lots of interesting work happening in that space, including work that Robin O'Halloran is doing, looking at social determinants of health, lots of work in the neurological sort of space as well. So I think all of that information hopefully hopefully all of this information will help us to answer some of those questions in the future.
Yeah, it's an important question, but it's a hard one to answer.
Yeah,
There's
right
a lot
now.
of research right now, yep. Maybe time for a couple more questions. Are you able to tell us something about how minimally important change will be established?
Yeah, I sure can. So this is, well, if you're a nerd, it's really interesting, but it's the way that
there's a
we're
lot of
going,
nerds on the call.
Lots of nerds, excellent. That's what I like. So there's lots of different ways of establishing minimal important change. The method that we are using is something that we've decided on in collaboration with the collaboration of aphasia trialists. And it's also come out of the work that the Cosman group do. And so we're using an anchor-based method, which means that we're going to prospectively collect our core outcome measures, but we're going to collect a global, like a Likert scale alongside those measures, on which people with aphasia and clinicians will rate their own perception of how much someone's language, their communication, their quality of life has improved since their last assessment. And then there's statistical wizardry that happens, and from that we're able to sort of dichotomize people into two groups. So groups that have shown improvement, more than expected improvement, and people who have not, and then we're able to determine a number on those different outcome measures. So the idea, to sort of boil it down to the most simple sort of I guess way of explaining it, is that ultimately we hope to be able to say that, you know, 10 points on this outcome measure is indicative of meaningful change. So it's a benchmark, yeah.
Great, and we might squeeze in one more. Kim Beasley's asking, are you intending to start collecting this minimum data set with new aphasia sufferers from now on?
So hopefully we'll be able to talk about this more soon, but this, as well as being part of Sally's PhD, will be part of a bigger project where we collect this data across a number of sites in Australia. So we will collect it probably across about 3 different sites, and it will be hopefully with every new stroke survivor who with aphasia who comes through those settings, and then we'll follow them up and assess them again so that we can establish those numbers.
Great. Well, I just want to say thank you again, Sarah, for presenting that huge, really important and probably very enduring body of work that will, be used for decades to come. So,
thanks for having me.
Pleasure. For our next CRE seminar, we're very fortunate to hear from Dr. Annie Hill, who's going to be presenting to us on preliminary findings from the first ICAP to be delivered by a tele-rehabilitation, ICAP being an intensive comprehensive aphasia program. That seminar will be on 31st of August, so make sure you're part of our community of practice or following us on social media for further details. Thanks for your time, Sarah.